Hello, my dear doctors. So, going to continue with our neurology station for the Mrcp cases, and today I'm going to discuss a very important topic, peripheral neuropathy, and this is actually, I must say, most common case in neurology. So, you should know it well and should be confident in diagnosing the peripheral neuropathy. So, let's move on. So, usually you are asked to examine the patient lower limbs. Command will be to examine the lower limbs. So suppose if you are examining the patients and you find that patient has a bilateral and symmetrical loss of power, which is suggestive of lower motor neuron type, or patient has bilateral and symmetrical loss of sensation, or there is a combination of these two, most distally, then the underlying pathology that should be mentioned is peripheral neuropathy. Suppose if the signs are only motor, then you should use the term peripheral motor neuropathy, and similarly if the signs are only sensory, then you should conclude that the patient has an underlying diagnosis of peripheral sensory neuropathy. If the patient has a combination of the above, then the underlying diagnosis is peripheral sensory motor neuropathy. This is just a broad brief review, and we're going to discuss later about the causes of these neuropathies as well. So, what will be the positive clinical findings you will be looking for? So, if the patient has a sensory neuropathy, there will be no motor involvement, no wasting or weakness, and the reflexes are preserved. Patient may have a bilateral sensory loss in a stalking distribution with impairment of light touch and pinprick, vibration, and joint position. So, posterior column may be involved. Romberg sign is positive in these patients. We discussed that previously in the cerebellar syndrome, the Romberg sign is usually negative. And the patient has an ataxia and high stoppage gait. So remember that in cerebellar syndrome also patient can be ataxic. Patient also can be ataxic in the peripheral, in the sensory neuropathy. So the important sign to look for is Romberg sign, and it is positive in the sensory neuropathy. So must examine for this sign. What about the motor neuropathy? What could be the positive clinical findings? There will be distal weakness or lower motor neuron type, reflexes will be depressed, and there will be muscle wasting. Wasting will be evident if the weakness is too long. So if you see the wasting, then you can already, it should be in back of mind that this is a chronic problem, and the sensations is normal. And about what about sensory motor? There will be combination of the above. So how will you present the case? You have done the examination, you have got some clue. So how will you present? Presentation is very important. Must practice your presentation, and you should be very fluent and confident. So this patient has bilateral and symmetrical weakness of his lower limbs, which is predominantly distal weakness. Must mention whether it's distal or proximal. We know there is a different causes for the distal weakness and proximal weakness. The weakness is of lower motor neuron type, as the reflexes are suppressed bilaterally and the plantars are downgoing on both sides. And there is also wasting of the muscles of the lower limbs. All modalities of sensations are intact and there are no cerebellar signs on examination. In summary, this patient has peripheral motor neuropathy. So here you can see we find all signs of the motor neuropathy. Then you will not stop here. You say, I'd like to finish by performing a full neurological examination to see whether this process is affecting the upper limb as well. And then I would like to take a full history, including the drug history. 6 minutes is very short time. You may not have enough time to do the full neurological examination, but in your presentation you must mention that what other examination you like to do. Briefly about the causes of neuropathy. If you find predominantly sensory neuropathy, diabetes is the most common cause. Remember that peripheral sensory neuropathy in patients number one cause is diabetes. Alcohol, there may be some drugs, vitamin deficiencies, B1, B12, and uremia. If you've got predominantly motor neuropathy, then we'll be thinking about Charcot-Marie-Tooth disease. This is quite common in PACEs. Or then GB syndrome, you must mention it, although you're not less likely to get the case of GB syndrome. But in some I think candidates got the GB syndrome as well. Malignancy, porphyrias, and lead poisoning. There are other causes as well, which include paraneoplastic syndromes, paraproteinemias, vasculitis, and infections like HIV or Lyme disease, and some cases are idiopathic. So these are the main causes. So remember, when examiner asks you about the cause of neuropathy, divide it into the sensory neuropathy, motor neuropathy. It will be quite easy for you. So what are the drugs which cause the peripheral neuropathy? There are a few drugs like amiodarone, isoniazid. We all know that isoniazid can cause peripheral neuropathy. Metronidazole, nitrofurantoin, phenytoin, and gold. Now it will be natural for the examiner that once you are given your correct diagnosis, then he will ask you how will you need to investigate this patient. So the patient, obviously, we would like to do the full neurological examination and you want to take a full detailed history. But this patient usually needs some type of test like nerve conduction studies to confirm the diagnosis, and we want to know the pattern of the underlying pathology, whether it is a demyelinating versus axonal disease. So, as I already mentioned, full history should be obtained, including the past medical history, drug history, family history, and social history, because the history is very important, because it may reveal the possibility of the peripheral neuropathy being part of the maybe as we can find symptoms of more generalized underlying disease. As we are aware that generalized disease can also cause the peripheral neuropathies like lymphomas, HIV, diabetes, thyroid disease, alcohol, inflammatory bowel disease, and any vasculitis, and inherited neuropathies like Charcot-Marie-Tooth syndrome. Okay. Then obviously we like to investigate further. We like to do some blood tests, including the full blood count, hematinics, urea electrolytes, inflammatory markers, and urine will be sent for proteins. More specific tests can also be carried out. If you cannot find any cause, then you want to do the protein electrophoresis. We want to do full antibody screen, serology for hepatitis viruses, thyroid function test, hemoglobin A1C. So if all these tests they fail to reveal the underlying cause, then patient may need to have a CSF analysis, MRI of the spine, nerve biopsy for the CIDP, and genetic testing for the Charcot-Marie-Tooth disease. So this is how you're going to answer the examiner that how you do the investigations. So I think that is all about the peripheral neuropathy. Very common case, so you must read it properly. So whatever resource you're using, just go through this topic. Thank you very much, and I'll see you